بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. الصلاة والسلام على سيدنا محمد حبيبنا ومعلمنا وقدوتنا صلى الله عليه وسلم. اليوم حبيت أتكلم عن موضوع مهم وبيجي الطوارئ دايما، وهي حالة من حالات الغسيل البريتوني. وهذه الحالة فعليا كانت موجودة عندنا في الطوارئ من أسبوع، وازاي نتعامل مع الحالات الإمرجنسي وخاصة مع حالات الغسيل البريتوني البريتونيال دياليسيس، وازاي نستفيد من كام درس النهارده هنتكلم عنهم في الحاله ديت، وازاي تفكر في الحاله دي لما تجي لك الطوارئ، وازاي تتعامل معاها كامرجنسي كيس، وازاي تتعامل معاها كبي دي بريسكريبشن موديفيكيشن. And all this will be discussed today just in I think the short presentation today. Just I will concentrate on this emergency case in our peritoneal dialysis. أولا بسم الله الرحمن الرحيم. قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. بسم الله الرحمن الرحيم. وقل اعملوا فسيرى الله أعمالكم ورسوله والمؤمنون. صدق الله العظيم. توكلنا على الله. الكيس اللي جات للإمرج مستر اتش ام is a 59 years male patient, CKD stage 5, he need dialysis secondary to polycystic kidney disease, and patient already preferred to start peritoneal dialysis for uremic symptoms. He just came to the clinic by nausea, vomiting, anorexia, insomnia, and itching, fatigue, all the uremic symptoms, with GFR, estimated GFR around 5 ml per minute, with urine output more than 1 liter per day. This is our case, presented to Emerg, and plan to start peritoneal dialysis. Already BD caster inserted and 2020 and started already in IBD regimen for peritoneal dialysis with fill volume 2 liters. This amount of fluid inside the abdomen of your patient around 2 liters, 5 cycles per day over 9 hours. Okay, his uremic symptoms after this regimen or start BD start to be improved, and already PET test done for him with high transporter type. High transporter and low transporter, we have 5 types of the membrane: high transporter, high average, and low average, and low transporter. High transporter mean our patient is this membrane is high transporter characteristic. He need rapid cycle, not CBD, or not doing well with the CBD. This patient after 3 months from start BD start to complain of short breath. After 3 months from BD start, he advised to increase fluid regimen by his doctor or whatever his nurse, and he called what I will do. I am complaining now of short breath increasing daily. He advised him just to increase the fluid regimen from 1.5% to 2.5% as usual. Okay, I think they should put here this 2 liter fluid regimen, 1.5%. In new start BD, you will start by low concentration. We have 1.5, 2.5, and 3 or 4.25. Like that, just to start from 1.5, then will increase 2.5 according to ultrafiltration and the patient volume status and the vital signs. 3 months after this 1.5, this prescription, the patient start to complain of short of breath. I have now short of breath. He call you or came to Emerg or came to your clinic complaining of this short of breath. Just you decide to increase his fluid regimen concentration, because if you will increase the fluid regimen concentration, this will remove more fluid as usual. Because most of us thinking this volume overload. And start for him Lasix 120 milligram oral BID just to increase his urine output with this concentration of the fluid. As we know, just simply our BD dependent diffusion from high concentration gradient to low concentration gradient. When I am increasing this fluid regimen to 2.5 with this Lasix, this will augment our ultrafiltration. After all the previous changes from BD fluid regimen and Lasix, he reported no improvement with UF on the cycle around 900 ml per day. It's good, but the patient is still complaining of short of breath. What is the problem now? We have good ultrafiltration, we already Lasix, we increase the concentration. You should think other differential diagnosis. Don't put all in your mind this just a volume overload. Advise him to start. You still insist in the wrong track. Advise to start long daily well. This wrong track already you are insisting to go through. You still insist this patient volume overload. You advise him to start long daily well and because the patient in IBD, just a dry day. Now the patient will day now. He will start as a CCBD. And 1 week later, seen in our clinic again, we are following him after 1 week. He's still complaining of mild short-term breath with no improvement, with good as saturation at room air 92%. You now just change the fluid regime from 1.5 to 2.5. Okay, 1.5 to 2.5, and added Lasix. And now you add Daydewell, and your patient still complaining of short-term breath. What would you do next? What is your action plan? What is your next step? What is your thinking now? With the patient, you are doing increased fluid regime, giving Lasix, and even giving Daydewell, because the patient only dry day, only night cycle. What is your next plan or next step for your patient? You think now or no? What is your thinking? What is your thought for this patient? What you will do if the patient still persistence, complaining of short breath, and you start a BD, and you increase fluid concentration, give Lasix, and giving extra Daydewell, you will keep him maintenance now in CCBD. This is impossible to be having with the usual patient. This is something wrong here. Patient still complaining of short breath, no improvement after all this previous modification. What would you do next? What do you think? What is in your mind now? What is your differential diagnosis? Okay. We already advised to do chest X-ray for this patient to find this moderate hydrothorax, right hydrothorax. Okay, this is by chest X-ray. Don't forget this. Not every patient with short breath means this patient volume overload. Maybe we have another problem. This is common in the BD patient. This right hydrothorax, and we'll discuss this next slides. What means by hydrothorax? Hydrothorax, this happens when we have communication here between the peritoneum and the diaphragm and the pleura, okay? This is the communication of the BD fluid between the peritoneal cavity and the pleural space, or presence of peritoneal dialysis fluid in the pleural cavity. Okay, this means definition of hydrothorax. What is incidence? Incidence around 1 to 2% or less than 5%. 1 to 2% is low, but you should put in your differential diagnosis any patient with short breath. And especially patient with polycystic kidney disease is high risk, because already we have polycystic kidney just taking large space from our abdomen and lead to increased intra-abdominal pressure. Don't forget this. Hydrothorax in BD patient with short breath, the communication between the BD fluid from the peritoneal cavity and the pleural space, and the presence of this peritoneal fluid in our pleural cavity. In incidence 1 to 2% or less than 5%. Polycystic kidney disease is the most common risk factor because they will increase the intra-abdominal pressure. What is the pathogenesis? Pathogenesis is movement of the dialysate under increased intra-abdominal pressure from peritoneal cavity to pleural cavity through congenital or acquired defect in the diaphragm. This way, maybe this if young like that, or patient with multiple congenital deformity or congenital disease, we can think in this. But what is the other explanation? Why? I need to ask you one question also. Will common to ask it for you. While hydrothorax common on the right side, we saw all hydrothorax in our BD patient on the right side, not on the left side. Is it because the left protected by the heart, or is this because the patient just dependent to sleep on the right side, or what is your explanation? Why most common right side hydrothorax in BD patient? Just we have different explanation, just personal opinions. Just from the right side, just maybe because the liver on the right side with the liver already mobile with the respiration, and he just traps some fluid between the diaphragm and the liver, and during the respiration and inspiration, this will do increase the pressure between the liver and diaphragm, and this will press on the diaphragm and lead to oozing this fluid from the peritoneal side to the pleural side. This is one explanation, because the liver doing this pressure by trapping fluid between liver and diaphragm. And the second issue, by ascending column, just push some PT fluid to liver. Just ascending column, just push same amount of PT fluid to the liver, and the liver will continue the same and continue increase the intra-abdominal pressure on the fluid between the liver and diaphragm. Or other explanation in congenital or acquired diaphragmatic defect. This is the main explanation why it's common on the right side more than the left side. And this is a picture taken by during a patient with video assisted thoracoscope. Already just taken by thoracic surgeon doctors, just doing huge intra-abdominal pressure by putting a large amount of dianyl or BD fluid dialysate in the abdomen, just increase the intra-abdominal pressure. When you increase, you will find this from the pleural side, just oozing the BD fluid here. This is the BD fluid already oozing inside the pleural cavity. Okay, so this weak wall or the diaphragmatic defect from peritoneum to alveolar space. Hydrothorax, what is the presentation? Maybe asymptomatic. Male patient asymptomatic, nothing at the start, but this time your patient start to complain of shorter breath, usually shortly after BD. We saw this already when patient with new start BD. Most the patient will start recently after start PD. And this is a short breath among most common famous symptoms. No improvement with hypertonic dialysate. عمال تزود انت في الدياليزيت concentration على اساس ان هو فوليوم اوفرلود وما فيش عندي تحسن للمريض. or diminished effluent return. عمال تحط 2 لتر يطلع لك لتر ونص. diminished effluent amount. and الوزن تاخد وزن العيان الويت جين. وزن العيان عمال يزيد 2 كيلو. هو وزنه 60 وصل 62 64 مع الوقت. Unilateral pleural effusion chest X-ray 90% on right side, as we mentioned before. The causes why common on right side. Diagnosis. What is the next step? What you will do next after chest X-ray? I discover now right hydrothorax. As a second step, I just will do thoracocentesis. Thoracocentesis therapeutic and diagnostic, just to relieve symptoms and for diagnosis of your patient. We'll send you this fluid analysis. We'll see if it's transudate or others. Just will check at the same time. Don't forget this. We'll send the just fluid from the pleura from thoracocentesis for glucose concentration with serum glucose at the same time. You will send both at the same time. When you are doing this thoracocentesis, you should send the peripheral blood for serum glucose, and will compare high concentration of glucose in our pleural fluid more than serum glucose. This was our diagnosis. Oh, but sometimes it's equal of the blood. Why? Because already with time we lost the concentration gradient already. If your patient chronic and keeps this fluid longer time, maybe more than 6 hours, now osmotic gradient equals the blood and the capillaries, and the blood sugar, blood glucose will be equal both peripheral and central. Don't surprise by that, because maybe this fluid chronically staying in the pleural cavity and the loss of osmotic gradient, just the blood glucose in the pleural fluid equals the serum with chronic staying pleural fluid from BD dialysate. And cell count, just also we can send the cell count. I think nothing to rule out infection or no. With other BD fluid, just don't forget high glucose concentration more than serum concentration. This with the BD fluid hydrothorax. What is next? What you will do next after thoracocentesis? We did already chest X-ray. After chest X-ray, we diagnose the right hydrothorax. What is after right hydrothorax? CT peritoneography. CT peritoneography. This CT was contrast already. How to order this? How to order this for radiology? Maybe already, this new PD starting dialysis center at your hospital. How to order that? Just CT was contrast at 100 to 100 or 200 to 1 liter or 200 to 2 liter, 1.5 burst dialysate. 100 or 200 ml IV contrast to be added to 1 or 2 liter dianyl or BD dialysate with concentration 1.5%, and should be taken and given during supine position and keep for at least 2, 3, 4 hours prior CT. اوكي، قبل ما تعمل السي تي خلي المحلول اللي انت اديته ده الكونتراست مع البي دي فلويد على الاقل 2 ل 3 ساعات، وبعدين تعمل السي تي بتاعتك وتاخد الصور بتاعتك. تمام، دي اشعه مقطعيه على البطن اهوت عشان تشوف الثقب او الفلويد هيتحرك من البروتينيوم لللنج ولا لا. دي اسمها سي تي بريتينيوجرافي. هنحط سي تي ويز كونتراست، هنحط 100 or 200 ml من الاي في كونتراست. لو 100 هحطها على 1 لتر، لو 200 هحطها على 2 لتر من الديانيل. الديانيل اللي هو البي دي فلويد اللي هو تركيزه 1.5 اقل تركيز 1.5 in supine position. ما تنساش supine position and to keep 2-3 hours prior CT contrast. Just attention here, please take, don't forget this, because the thoracic surgeon or your surgeon may be like this methylene blue. And this methylene blue is prohibited or a little bit not recommended because it will end by peritoneal sclerosis and also painful with chemical peritonitis. Painful when you inject this methylene blue, and will end by chemical peritonitis and peritoneal sclerosis. This methylene blue not lovely to nephrology. Methylene blue, how to surgeon prescribes the dose 20 milligram. Don't forget 20 milligram. This equal 2 ml, and yes, will be mixed with 1.5% fluid regime on call to OR. Before we can use this before fats. What means by fats? Fats is video assisted thoracoscope. This will do pleurodesis and will close the hole between the diaphragm and the pleural cavity. And thoracic surgeon like to prescribe this methylene blue 20 milligram. That equal 2 ml and 1.5 of fluid regime, 1.5% on call to OR, still used by some surgeons till now. What's the next? What you'll do next after this? After thoracocentesis, keep the other method to diagnose this, because if some patient was chronic, you will find no difference in glucose between the pleural fluid and the serum fluid. Another Dr. Jeff Bear at St. Michael Hospital recommended this after thoracocentesis, just to keep pigtail on one night only, just to keep البيجتيل just one night during a regular BD cycle. هتسيب بيجتيل، هتسيب الدرنقه ديت يا سيدي ليله واحده، وتخلي العين يغسل طول الليل على البي دي. سايكلز بتاعته بيعمل 5 سايكل، خليه يعمل 5 سايكل زين تشيك، وبعد كده بتشوف ثاني يوم الصباح بتشوف يا سيدي الاماونت عند الكونتنت اوف ذا افلانت، تشوف الكميه بتاعته قد ايه، وبتشوف الكونتنت بتاعته. لو لقينا طبعا الجلوكوز از هاي، this surely diagnosis we have this BD cause of this right hydrothorax or hydrothorax. Okay, in the next day I got another way that help you for diagnosis of BD hydrothorax. BD as a cause of hydrothorax after thoracocentesis, just to keep a pigtail just one night during a regular and continue patient regular BD cycles, and the second day you will check effluent or drain amount from this pigtails او الدرنقه ديت، وتحاول تحلل تشوف البلاد جلوكوز في البي دي درينز في البي دي في الدرنقه ديت، وساعتها ده هيكون good diagnostic test for any BD hydrothorax. This is the third method to diagnose. How to manage? زي ما قلنا thoracocentesis is the first line of treatment, just symptomatic and diagnostic, and very may be helpful in a very short breath patient with severe short breath. And second, discontinual BD. This is the second step. Thoracocentesis first, discontinual BD second, and please temporary hemodialysis. Don't think more. Temporary hemodialysis, if dialysis is necessary, if your patient high risk with uremic symptoms, hyperkalemia, metabolic acidosis, volume overload, please IHD, intermittent hemodialysis for 6 weeks, 1.5 months to 1.5 months, and then after that you can challenge this BD again, and this is successful in 50% of the cases. When you return to BD again, 50% of the cases will continue BD. يبقى management of any hydrothorax, first line thoracocentesis, therapeutic and diagnostic, discontinual BD, and temporary hemodialysis for 6 weeks, and then retrial BD again with your patient, and this will be successful in around 50% of the cases. Okay, I hope that's clear now. And continue as management. When you resume BD after 6 weeks, just please a small amount. If the patient taking 2 liters, you can resume just by 1 liter, and you can do 3 cycles, and you can do in supine position, just to be gentle and be in a sitting position, not supine position. Need the patient sitting, don't do more pressure on diaphragm. Sitting position is preferred position to return PD with a small low intraabdominal pressure with small volume. And management is second management. We are doing here pleurodesis with using this video assisted thoracoscope with expert thoracic surgeon or general surgeon, expert on that part. And is doing pleurodesis just using talc, most common now. Also other history of tetracycline, bleomycin, fibrin glue, and antiplasmin and autologous blood. All this used to plug the hole between the diaphragm, but the most common is talc. And this video-assisted thoracoscope with expert surgeon will get more than 50% success after that to resume the patient BD. Operative or fluoroscopic repair, the same issue for diagram. Some patients need to be open surgery and some using this thoracoscope according to the available and the experience of your surgeon at your place. Our case, the patient hemodialysis started for 6 weeks and the fluoridesis is already done with talc using this video-assisted thoracoscope. Already this is done, okay? After 1 month, the patient resumed his BD and again, he was follow-up. We found his recurrence already is his pleural effusion. What we'll do after 2 months from that, patient insists to continue BD and he asked for another more fats video-assisted thoracoscope and repeated that with betadine. And 1 month later, he resumed his BD after that, after the second time. In IBD night cycle, small amount, sitting position, and follow up for 2 months. After that, the patient is doing perfect and continue PD. Don't lose hope. If the first trial is failed, you can try second, third, because the PD is totally different from hemodialysis. And some patient is too happy with the PD. She's free to be travel, at least we can do at home, at night, whatever. Patient dependent, not hospital dependent and nurse dependent, and the patient can go everywhere, anywhere by his BD. And the patient who adapted on BD, he need to continue on BD and try your best. If you need to increase your load or your rate in your hospital or in your place for number of BD patients, just try your best with your patient as you can. Don't be easily transfer patient from BD to hemodialysis. Just try and do all your best with your patient to keep your BD patient to a safe situation and away from hemodialysis as you can. Case number 2, Mr. AM, a 60 years old male patient in end-stage renal disease secondary to diabetes mellitus. Please concentrate with me. This is the most important case now. He's a 60 years male patient in end-stage disease secondary to diabetes type 2. Started in ABD, volume 2 liters with 5 cycles over 9 hours. After 1 month, start to complain again of short of breath. After 1 month from recent started dialysis, start to complain short of breath. And his hypertension with no edema, with ultrafiltration 800 and the fluoride regime 1.5%. What is your next action for this patient now? The patient on 1.5%, blood pressure a little bit high with short of breath and 2 liter, 5 cycle, 1.5%. What do you think is the next step for any patient short of breath in BD patient? What's your action now? I will give you multiple choice. I will not let you to think more. Please just think with me and read this urgent, please, and rapid. To increase fluid regimen from 1.5 to 2.5 because the ultrafiltration is low, ultrafiltration not low. The ultrafiltration is okay, is 800, 900 is okay. And get bit test, maybe high transporter, need more cycle. I think I will wait for bit test with patient short of breath. I think not the option. Chest X-ray, start Lasix. What's your choice now? I think the best action, any patient with BD, with short of breath and recent start dialysis, please do chest X-ray. Chest X-ray, and already this patient already is the first clinical pearl I need to give for you today. Not all short of breath is volume overload. Maybe this hydrosource as a complication from a diaphragmatic congenital holes or mechanism we discussed before, and this patient suffer now from this right pleural effusion and misdiagnosed as volume overload. And you try to give Lasix, try to increase the fluid concentration, try to increase cycles, and no benefit. And the patient continue just before to do anything, just to do chest X-ray first. Any patient with short of breath, not all volume overload. Please check for hydrothorax in recent start BD patient with short of breath. Remember, I need you to put this in your mind. Any new BD patient, this will receive many calls from a BD nurse for that issue. Any new BD patient with rapid lymphatic absorption to peritoneal capillary. rapid lymphatic absorption of our BD fluid to the peritoneal capillary early, and the early start BD and negative ultrafiltration even with ecodextran. Any patient new start, the nurse will set for you, I give 2 liter, he give for me only 1.5 liter, 1.6 liter. He's trapping inside his abdomen around 200. This is because this rapid lymphatic absorption to the peritoneal capillary and just filling the intra-abdominal spaces and suckers. All this will, with any new patient start BD dialysis, don't worry for that, okay? Any patient came by negative ultrafiltration, don't worry for that. This is the mechanism, first mechanism for any new start peritoneal dialysis patient. Other mechanical issue with a new start BD fluid leak, some abdominal edema will be found this because it's a little bit leaks, but nowhere else, not in pleural effusion like as we see. And the mechanical catheter problem, low ultrafiltration but slow catheter inflow, outflow. This mechanical problem will be facing with any new start BD patient, either BD fluid leak with abdominal edema but nowhere else. Mechanical catheter, not inguinal hernia, not pleural cavity like that. Mechanical catheter problem, low ultrafiltration but slow catheter inflow and outflow. This will be faced in new start BD patient. New cardiac dysfunction. You don't forget this new cardiac dysfunction. Maybe your patient, when he arrived in the stage, this is the most common cause of this in our dialysis patient is cardiology or cardiac problem. Just maybe develop recent MI, maybe develop recent diastolic dysfunction, recent heart failure. You should follow up with the echocardiogram and to check in ejection fraction and diastolic heart failure, ECG cardiac enzyme to be routinely in this order for any patient with short of breath. Resolution of uremia. You know, after your patient started dialysis and uremia improving, good appetite including, and lead to more salt and water intake. This lead to short of breath and volume overload. Okay, don't forget this slide for any new start BD patient. This is a second clinical pearl today. Please check your patient diet. Don't, any patient came by short of breath, volume overload, lower limb edema, chest X-ray is congested. Please check your patient diet to know how much salt and water your patient taking daily. You should ask, we should check what is your food, your patient food intake, and how much is processed food. From our side is high salt and water intake already for your patient. Our case for this patient, fluoridesis done with talc, temporary IHD intermittent hemodialysis for 6 weeks, then resumes his regular ABD, but little amount, 1.5 liter, 5 cycle over 9 hours, and the bed test already done. High transporter with UF 600, urine output dropped to 1 liter per day, and on examination, mild edema, and blood pressure is hypertension, weight gain around 4 liter, BDF ultrafiltration 900 is perfect, current fluid region we change from 1.5 to 2.5, all blood work at the target. What is your next step? My patient is still edematous, and the urine output drop, blood pressure is high, and the weight gain, and the ultrafiltration I think is perfect. Now what we'll do, and the transporter, and his own ABD is okay, and his 1.5 liter, what you will do next? What you'll do next for this patient, edematous and hypertension and weight gain, and this ultrafiltration is okay, and the fluid is okay. You will consult a dietitian to educate your patient about salt and water, or you will start Lasix, or you will use all fluid region 2.5%, or A and B, or 1 and 4. I think my answer here, consult a dietitian to educate your patient about salt and water intake. This is number 1. Any patient with volume overload, lower limb edema, hypertension, short of breath, all this should be check his diet for salt and water and consult for nutrition and start Lasix for him. Then the third clinical pearl for our patient, residual renal function, use it and don't lose it. This third clinical pearl, just any patient with residual kidney function, whatever, even 50 ml urine per day or 100 ml urine per day, just use it. Use this, but don't lose it, okay? Don't lose it. We discussed already in the previous BD emergency case with pulmonary edema And the benefit of residual renal function I already ran on the last presentation before on LBD. If you like to hear for residual renal function and the benefit on survival and the outcome of your patient. Now, the third clinical pearl today, residual kidney function, use it and don't lose it. As here by our Professor Dr. Abdelhamid at UHN, she's like to keep any or to preserve any residual kidney function, even urine output, even 10 ml. This will, as by her already, urine volume 250 ml daily, with greater survival on greater benefit on survival and the outcome of your patient. And will get this will help your PD patient doing well during your peritoneal dialysis. Please keep this or use this and don't lose this any residual kidney function, as by Dr. Abdelhamid said for us. And here, as regard the diuretic use and residual renal function, here we have two groups of the patient. Just read one. This red group already use only just Lasix, and the other blue one using Lasix and hydrochlorothiazide and spironolactone, and already just the difference only in water removal, not sodium removal. Okay, we have no benefit in sodium removal, just water removal is high with the patient, with group of patient receiving this combined diuretic, Lasix, hydrochlorothiazide, and spironolactone, just water removal, not sodium removal. No difference in sodium removal between groups, using just only Lasix, and the other groups using this three diuretic. You will not get any benefit in salt removal. We are not concentrated only in fluid removal. We need also salt and fluid removal. And if loop diuretic just improve clinical outcome in not only in PD patient, also in hemodialysis. This will keep your patient away from hospital for volume overload and visit Emerg, according to this study, and intradiuretic hypotension from volume overload and more ultrafiltration will go to hypotension, and intradiuretic weight gain, no more weight gain because we have already diuretic, and this will keep our residual renal function. We are using our residual renal function, and the mortality, I think all this better with patient with diuretic versus non-diuretic groups. Our case started already Lasix, metalazone 10 milligram. I think no benefit from metalazone, just Lasix is enough. And ABD 2 liter, 5 cycle, 9 hours, dry day, and all fluid regime now 2.5%. With ultrafiltration is okay, 900 to 1,200 ml. Urine output drop 2 to 200 ml per day. Still with significant edema, hypertension, and weight gain. Oh, you give Lasix now, and you change the fluid regime 2.5%, and the urine output drop from 1 liter to 200 ml per day. And now our patient with significant edema and hypertension and weight gain around 4 kilograms. And the phosphorus now before all his blood work at the target, and the phosphorus now is high, and the bit already done before is high transporter already, we know that already in ABD, and the dietitian already seen and discussed with patient about low salt and low water intake, and decrease any processed food because high sodium content. What is your next action? I need you to think now what I can do next. What is missing here in his prescription? He received already Lasix diuretic, and his cycle already, the fluid regime increased to 2.5 and 5 cycles, and his urine output decreased, and the edema increased, blood pressure increased, the weight gain increased, the phosphorus increased, and dietitian already seen for low salt, low water intake. What is your next action? You think already? I will give you a choice. Switch the patient to hemodialysis is very bad action from you to shift the patient from BD to hemodialysis because you can't adjust his prescription. This is a wrong choice. Bit test already, your patient done already, no need to repeat. What is the benefit to repeat? Added last fill ecodextran, maybe will work. Increase the LPD number of cycles, 7 cycles, and the treatment time 11 hours. I think is not good option also. You will keep your patient trapped with the machine 11 hours or maybe 12 hours per day, half day on the machine. Add the last fill of dianyl. Maybe you will see If this will work or no. Use all 4.5%. I think not good option because high concentration will lose our membrane function with the time, fibrosis, new vascularization, and not good option for him. Just will keep this concentration only for pulmonary edema better. What is your action now? What your choice? What you chose now from this multiple choice for your patient now? What's your next action? You think already? Okay. Just the best option to add last fill ecodextran. Okay. This is the best answer for this next action for your patient. This is the first clinical pearl. Salt removal, not just fluid removal matters. What does it mean by this salt removal, not just fluid removal? هنا لو انا اخترت 4% اور دايانيل دولت عباره عن جلوكوز، دولت بيلعبوا على الاكوابرين اكتر من الاذر بورز to remove more solids. فدولت اكتر بيعملوا water ultrafiltration more than salt اللي هم الجلوكوز whatever the concentration. But the ecodextran already work on the middle molecules and large molecules. Okay, this is by ecodextran with long dwell, as by many studies done before, with a long dwell just help to remove more beta-2 microglobulin and more phosphorus and just to work in both direction, fluids and solids, and the large solid, middle and large molecules. But this is in comparison with dianyl. Okay, salt removal, not just fluid removal matter. Don't forget about long day dwell. Don't forget this. If you have your patient 5 cycle, 7 cycle, and his dry day, please ecodextran long dwell for his day. For more understanding, look for the next slide. Don't forget about long day dwell. Who is the best fluid option? As I mentioned for you, if I will use glucose, whatever the concentration, with frequent cycles, with high fluid regime, 4.25%, it will remove more water than a sodium removal because he will play, look here, he will play more in the aquaporine, more than the middle and the large pores for the middle and large molecules. Just for high concentration of glucose will remove more fluid, not salt. I need both, not only salt. Here, ecodextran is associated with sodium coupled fluid removal. Here sodium, we found the red one is sodium with the water. Now ecodextran associated with couple sodium removal coupled to fluid. Okay, we remove more solid than fluid. This we prefer long dwell to be ecodextran. Ecodextran, he is working well within, he can give you a good ultrafiltration with salt and the clearance within 12 hours, I think. Is working well, ultrafiltration volume and dwell time, I think here until 13 hours or 12 hours, after that will drop. Better to continue maybe 12 hours, 8 to 12 hours is best for him. 15 hours here and 12 hour maximum, and I think after that will decrease the oncotic pressure for him. This is the ecodextran, okay? This does to show ecodextran work maybe until 12 hours. Just to remind you, ultrafiltration in BD fluid, and we have fluid regime 1.5 and the fluid regime 4.25%. Fluid regime, the lowest fluid regime, maximum ultrafiltration 330 plus or minus 187 ml on maximum time 140 minutes plus or minus 48 minutes. Maximum time 140 minutes, 140 minutes. Don't do lower than this time, okay? And the fluid regime 4.25 maximum ultrafiltration 1028 plus or minus 258 ml. Time to maximum ultrafiltration to 247 minutes plus or minus 60 minutes, okay? 247 minutes plus or minus 61 minutes. Don't forget this. This is the ultrafiltration from our BD fluid regime. Fluid regime 1.5% maximum ultrafiltration 330, and the fluid regime 4.25% maximum ultrafiltration 1028 ml. Okay, and with each time, with each amount is time for that. Just one question, if you have one patient, just another example test for you, 60 years in female BD for 2 weeks, develop short press, already chest X-ray done for her after we discuss all this presentation, and already show with large right pleural effusion. What which of the following statement is the most correct? If you read this pleural fluid glucose should be at least 200 milligram deciliter higher than simultaneous blood glucose, or pleural fluid should be transudate, or pleural BD fluid criteria for BD proteinitis more than 150% neutrophil. The more common BD to be in the left side is rare. It's more common for BD hydrocephalus to be occurs in patient more than 60 years. I don't know, this is not good answer, and there's not good answer. Just this transudate or this. I think this is the best answer, number one. And just a collection done for inhibition to short breast volume overload, just a dietary salt and water restriction, and then increase his diuretic to the patient with good residual renal function, especially if more than 100 ml urine per day. Try to use this, don't lose this residual kidney function. Optimize his peritoneal sodium and water removal by this just fluid regimen and long dwell by ecodextran, and this other is multiple choice for multiple prescription how we can use dextrose and ecodextran by different steps. As we discussed before, summary for our clinical pearl, I need to message for all my colleagues today. Not all short press is volume overload. Not all short press is volume overload. Know how much salt in your patient diet or eating. Know how much salt your patient is eating in his diet. Know how much salt in your patient eating in his diet. Okay, this is the second message today or pearl. Residual renal function, use it, don't lose it. Use it, don't lose it. Don't forget diuretic, Lasix 120 BID. Enough, no more diuretic. Salt removal, not just fluid removal. Don't increase only concentration of your BD fluid, just think in other fluid type or BD fluid type like ecodextran. Salt removal, not just fluid removal, we discussed this before. Don't forget about long day dwell. Long day dwell by ecodextran. This will help to remove middle molecules with another large solutes like phosphate. Just ecodextran from 8 to 12 hours. And the permissive edema, this last clinical pearl. Don't, don't keep your patient, don't let your patient lose if there is renal function by your giving ecodextran and high concentration of fluid region, and the patient will go to hypotension and volume depletion, and he will lose his residual kidney function, and this residual kidney function is important for patient survival and outcome and the hospitalization and the mortality and intradiabetic weight gain and intradiabetic hypotension. All this will be protected by this residual renal function. Just don't over dry your patient. Just clinical assessment to your patient for any signs of volume overload. This is the job of BD clinic. Your job in BD clinic to assess your volume of the patient. His patient is volume depleted or volume overload. Don't lose your patient residual kidney function by good assessment in each clinic visit, and use this residual kidney function by use diuretic, whatever, Lasix 120 BID. But permissive edema, we need by this term, permissive edema, just don't let your patient to go to dry side and hypotension, he will lose his residual renal function. Just to keep him euvolemic as you can. Let him little bit wet, not too dry, not hypertensive, not volume overload. I need my patient on borderline, blood pressure is okay, on target weight. This my means on target weight, and let him little bit in the BD patient, keep him in the weight side if he with good residual renal function. This is the last message for you, and I hope is reach for all. ولا تنسوا دايما الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. دي وصيتي لكم وده اللي أنا عايزه منكم. أنا أسألكم الدعاء بالتوفيق والسداد والبركة في الصحة والمال والأولاد والوقت، ونسأل الله أن يقدم لكم المزيد. وإن شاء الله أي حالة إمرجنسي وحالة انترستنج وحالة هتفيدكم في شغلكم أو في الكلينيكا أو في التعامل مع العيان طبعا ما هنتأخر وهنحاول نقدمها بأسرع وقت. والله المستعان، وإن شاء الله نلقاكم على خير وفيديو قادم إن شاء الله. نلقاكم في رعاية الله ونترككم في رعاية الله وحفظه. والسلام عليكم ورحمة الله وبركاته.